Dr. Tejaswini. I'm consultant clinical hematologist. I work in Shumaga. So I have selected the topic reluctance to diagnose hematologic malignancies as a topic of discussion for today. Thank you all for joining. So I felt this is a very relevant topic for the current situation of how hematologic malignancies are dealt with in a peripheral center, in a peripheral ti- tier 2, tier 3 city like Shimoga, which is not very near to a metropolitan city, but of course there are a good number of uh, doctors, pathologists, and diagnosticians and physicians. So there is a lot of reluctance to diagnose hematologic malignancies. In the past 10 months of my practice, whatever I have faced, I wanted to present a few cases, but I have kept it to published literature. So here are few. So I selected this article, which is published in BMC Hematology 2013, which is which is about a 12-year-old article from the UK, but it is very relevant to my current clinical practice here in Shumaga. The article is titled Time to Diagnosis and Symptoms of Myeloma, Lymphoma, and Leukemia, a report from the Hematologic Malignancy Research Network. So the UK Hematologic Malignancy Network routinely collects data from all patients newly diagnosed with myeloma, lymphoma, and leukemia. So annually, there are more than 2,000 cases from a population of 3.6 million. So the duration of the total interval, that is from the onset of symptoms to the diagnosis, whether it is the patient interval, symptom onset to help seeking, or whether it is the diagnostic interval, that is from the point where the patient seeks help to diagnosis, was examined by patient characteristics and diagnosis. So this is something which we are seeing here also. Since my center is about 250 kilometers away from metropolitan city like Bangalore, the nearest. So these are some of the cases, similar cases we are seeing here. These are some 7 to 10 cases have been described in this article, which I would like to highlight. 1 minute. I have.
So it's normal. TSH.
Okay. So this is one of the case that has been described in this article. It is a 30 to 40-year-old patient who presents with vague symptoms of pain in left shoulder, left side, pain in the left side of the chest, not able to lie down, tiredness, breathlessness, cough, weight loss, and coughing up blood. Here we can see that apart from coughing up of blood, which could have been a very late symptom, everything else is vague. Unless he had breathlessness early, he wouldn't have presented to the doctor very seriously. So the patient this is actual text written by the patient. He went to the doctor at least 8 times. The doctor kept telling him that it could not be anything serious. And when the patient, and he was very young to be worried about these symptoms. Probably when the patient had tiredness and breathlessness, they have gone for an X-ray. And between the time patient had symptom to seeking help, it was immediate, but the doctors took about 5 months to come to a correct diagnosis. Small. Okay. The second case here they have described is again a DLBCL, 70 to 80-year-old patient presented with tiredness and lump in the neck. So patient had symptoms for 3 months before he actually contacted a clinician. And after contacting a clinician, they have taken 2 months to come with a proper diagnosis. Yet another case here, 50 to 60-year-old presented with ache in the bone and joint, general mood change. So myeloma is known to cause hypercalcemia. This hypercalcemia can cause very vague symptoms like mood change, psychosomatic disorder-like features, and also constipation. So the total time interval from the first onset of symptom to help seeking itself was very prolonged here. It was almost a year, and the many doctors have just called him a hypochondriac. 50 to 60-year-old, walking well with small amount of joint pain, but some amount of mood change, probably is a hypochondriac. This is what this patient has faced. So few other cases here, 60 to 70-year-old. This patient had hip replacement already. So since he had hip replacement already and he had further symptoms, it was ignored. And in spite of that, the patient has said that this backache which he is having currently was something more than what was because of the hip replacement. We don't know whether the hip replacement had was part of osteoporosis or some other lesion or some lytic lesion because of myeloma, which was also missed. So the patient was diagnosed 1 year later with myeloma. Similarly, myeloproliferative neoplasms in the young can be very difficult to diagnose. Here is the case of 30 to 40-year-old with itching, red-brown speckles on the toe and ankle. He had migraine. So what he says is, although I was aware of the symptoms for some time, I had put them down to other potential causes like food allergy, freckles, migraine, etc. And here in this case, the patient has presented to the doctor after a long period of 18 months, and after that, they have taken a year to diagnose a myeloproliferative neoplasm. Here is another patient, 60 to 70-year-old, who was very lucky. He was routinely getting his insurance checkup and medical examination lab investigations done, and he was diagnosed incidentally. There is a problem with patients who are diagnosed incidentally because they do not have any symptoms. They do feel that they have been overdiagnosed or the doctor is a little crazy. He is looking for more cases and he is jobless. So he is coming up with new ideas to treat me. So AML, 40-year-old, similarly, patient took 2 months to present to the doctor, and then AML, luckily, this patient has been examined by peripheral smear and he was diagnosed in a day. Why is there such a heterogeneity in the diagnosis of hematologic malignancy? Certainly, the subtype determines the aggressiveness, both of the disease, the symptoms, and also the way the reports of the patients will. Can I pause for a minute?
Yes, ma'am, you can do, ma'am. We can edit the part.
So, largely the symptoms determine how early they present to the um, clinician or how early they even tell their family members. If they diagnose incidentally, as I said, there's a lot of disbelief. So, in a place where routine hematologic tests are done, routine investigations and either for the patient's own benefit or for the insurance sake are done, 1/3 of hematologic malignancies could be diagnosed incidentally. So this is just a brief outline of the WHO classification of lymphoid and myeloid neoplasms. We know that from the 4th edition to the 5th edition of uh, hematologic malignancies, the tumor-like lesion of B and T cells have been included. So this, I'll just go through these slides now. And when we come to the laboratory aspect of diagnosis of hematologic malignancies, I'll come back to this. Or if there are any questions, we know that there are B cell tumor-like lesion, B cell acute lymphoblastic leukemias and lymphomas. And then there are chronic B cell neoplasms. Then, and also there are cutaneous B cell neoplasms. And then there is the large B cell lymphoma. Large B cell lymphoma is the most common lymphoma in the current hematology practice, both in the West and India. We know that DLBCL could present like many other things. There are a lot of risk factors for DLBCL, whether it could be an Epstein-Barr virus infection, whether it could be a chronic inflammation, fibrin deposit, fluid overload, and there are several plasma cell leukemias, lymphomas, Burkitt lymphoma, and also we are familiar with the Kaposi sarcoma herpes virus, which could cause several lymphoma-like and lymphoid lesions. So there are several lymphoproliferative neoplasms which could be related to immunodeficiency, whether it is congenital or acquired immunodeficiency because of iatrogenic causes. I'll come back to these things when I tell how these lesions could be missed because of some of our overlooking etc. So Hodgkin's lymphoma, we are all familiar with Hodgkin's lymphoma, plasma cell neoplasms. There are many new entities that have been described in the current WHO. And then there are the T cell neoplasms. T cell neoplasms, if any pathology colleagues have joined, they will be very familiar that T cell neoplasms can look like a reactive lesion, reactive lymph node, etc. Tumor-like lesions in T cell are also known. T lymphoblastic lymphoma is the one which is easy to diagnose in a young male patient, adolescent or young adult. It is easy to diagnose, but a mature T cell neoplasm in the elderly could have very vague presentation. So also the primary cutaneous T cell lymphomas, which could have a very vague presentation. We'll come back to these. This is just a brief outline of the various neoplasms that are seen in the hematology. The recent WHO has also defined some new entities like severe mosquito bite allergy is also thought to be a pre-malignant lesion. The chances of it turning into malignancy is very rare, but yet it has been defined as a pre-malignant lesion. There are various dendritic cell neoplasms and splenic non-hematologic neoplasms. Coming to the here are some lymphomas which are prevalent in the immunoprivileged site. Here also the symptoms are very vague. Suppose a CNS lymphoma or a lymphoma in the vitreoretina or in the gonads will be very vague. The symptoms will be very vague unless focused investigation is done for these lesions, we are likely to miss. Similarly, the lymphomas of the gastrointestinal tract can have very vague symptoms and could also be missed. And, apart from the lymphoid lesions, we have the myeloid lesions, we have the myeloproliferative lesions, CML, polycythemia vera, which are quite familiar for the general clinicians, but there are other lesions like essential thrombocythemia, neutrophilic leukemia, eosinophilic leukemia, JMML, etc. And then there is a wide spectrum of myeloproliferative neoplasms not otherwise specified, which are vaguely described and difficult to diagnose. Also, there is a set of lesions called mastocytosis, which could have a vague cutaneous manifestation, or it could have a systemic manifestation with bone marrow lesions and smoldering punched out lesions in the various bone. When I say bone marrow, only the marrow is involved. When it is a smoldering or aggressive mastocytosis, there could be punched out lesions similar to multiple myeloma in a mastocytosis case. So also there are myelodysplastic neoplasm. What was called previously as myelodysplastic syndrome is now called as myelodysplastic neoplasm. This is a very vague entity because all of these will definitely require a bone marrow examination and also very focused approach and by the pathologist. A little confidence in diagnosing this is also and a lot of experience is required, because if you have to identify 5% blasts in a bone marrow cell smear which is having 5,000 cells, and if you have to say that the percentage of blast is less than 5, if you have seen 500 cells to diagnosis, there are various things that can be done to reduce the time to diagnosis. We can increase the public education campaign. We can do more of public education campaigns, and there could be refinement of the existing referral guidelines, and general practitioner decision making aids could be given to the various doctors. The problem here is the general practitioner has to look into various problems. The patient, when the patient, like suppose our favorite Punit Rajkumar went to the clinic, we really don't know whether he had a heart attack or whether he had a thrombus. What happened when there is a certain amount of panic when a patient comes to the clinic. He has to look into everything. There is a lot of things he has to look into. It is not a joke that you have to have a focused approach, while keeping in mind that he has to have a focused approach for each system. The general practitioner has to have a which is very difficult. It is unreasonable to expect him to have so much of a presence of mind. So it is useful if we can give them decision making aids and proactive diagnostication. When I talk about proactive diagnosticians, there are a lot of labs in almost all towns, whether it is a big city like Bangalore, Mumbai, Delhi, or whether it is a a town like Shimoga, Mysore, etc. There are a lot of labs. Many labs are run by very well trained technicians and also pathologists. The technicians often have diagnosed very difficult AMLs, but the new freshers from pathology, I am a pathologist. My basic training has been in pathology, and then I have gone into the clinical mode. I know how it is when you first see your AML slide in a exam hall and when you first see a AML slide in the clinical practice. It is often difficult to even say, suppose the senior is telling that it is not AML, and if I want to call it AML, there is a certain amount of fear in the diagnosticians also, and they have to be proactive. They have to take history. It is unreasonable even here also, because the person running the lab will want you to report on 150 slides a day. It is unreasonable that every slide will get the due importance. Both the referring doctor who has sent you the case should tell you that this is what I want you to see in the slide, and the diagnostician, suppose you see a abnormal slide, you have to go back, call the clinician and ask them. So shifting gears, shifting to the lab side. So this is a very favorite spotter for the pathology residents. This is a, does anyone want to unmute yourself and answer? I don't know how many have logged in. So this is a Faggot cell. This is a very favorite spotter even for the undergraduates and definitely for the pathology and lab medicine postgraduates. So if you get this slide, you are likely to clear the exam. But when you come to the clinical practice, it is important that you call back the clinician and inform immediately. This is one example I want to give, because Faggot cell is quite diagnostic of acute promyelocytic leukemia, and this disease, similar to acute myeloid leukemia, has a bad prognosis. But compared to other acute myeloid leukemia, if the treatment is started early, the patient is likely to benefit. It has been told to doctors right from the undergraduate and postgraduate days, but I think it deserves to be reiterated. So this is a article published by Talman. It is titled "How to Avoid Early Mortality in Acute Promyelocytic Leukemia." This is a smear which shows all these cells, promyelocytes. A case of 32-year-old man with 2-week history of headache and easy bruising presented to medical attention for headache. So when this case is published by Talman, who is considered as a um, very senior authority in acute myeloid leukemia, when he is telling that in his center the patient is presenting after 2 weeks, it is not surprising that in a peripheral place like a remote town in Karnataka, the patient would present after 3 weeks. So we usually see these patients are presenting with headache. They go to the primary care physician, and then they go to the various doctors. Generally, we do not ask for a CBC when the patient presents with headache. Suppose we ask for a CBC, the chances of the smear being seen is very less. Suppose the counts are low, then the chances of it being treated as dengue is very high. So suppose the patient is having hemoglobin of 5.9, and unluckily if he is having a microcytic hypochromic picture in the CBC, and he is also having low platelet count, the chances of him being treated as a viral fever, whether it is dengue, chikungunya, or any other like Casanova forest disease, he will be treated initially as a viral infection unless the smear is seen. What I am trying to highlight here is as far as possible, try and order for a peripheral smear. These doctors called pathologists, they are trained for 3 years. At least 6 months in a year, they are posted in hematology, 3 to 6 months. So minimum 9 months to 1.5 year. They have focused training in hematology. Unless you ask for it as a general physician, unless you ask for it, they do not have the time to go and see every slide for. And definitely the pathologist also, when they see a low platelet count, low hemoglobin count, they should go back and see the smear, and uh, uh, instead of seeing the MCV and reporting it as microcytic hypochromic without seeing the smear, it will be of value for at least one person. Maybe one person in 100 slides you see may be benefited, but certainly it will benefit him. So, similar to what I said for the lymphoma, here the APL patients, the lower panel here is the patient interval. The patient may take up to 15 days. In case of a AML, the patient may take up to 15 days after he started having fever and tiredness to even present to the doctor, or even tell his family members or tell his neighbors. So, in case of APML, it is slightly shorter. After presenting to the diagnostician, the diagnostic interval may take anywhere between 5 to 10 days. After diagnosis, the interval the time to treatment may take from anywhere from immediately to 5 days. Why this is significant? We may not be able to reduce this time, the patient interval in this era. Maybe it may take 5 to 10 more years before we can reduce the patient interval, because the patient awareness will always follow the doctor awareness. When the doctors are aware, we can make the patients aware. We can certainly cut down on the diagnostic interval and the treatment interval. So, as I said, acute promyelocytic leukemia, similar to other acute myeloid leukemia, is very fatal. But it can be treated because it has specific drugs. It is known to cause early death because it has both hypercoagulable state and a fibrinolytic state. What does this mean? The patient can have clotting manifestations. The patient can have bleeding manifestation. So it is very important to start the treatment very early. So the evolution of APL therapy has been very dramatic from 1957 onwards, when early on it was treated with anthracycline. The response to treatment was very different from the response which was seen in other AML. Luckily, they have found in the 1970s and 80s, they have found that ultrans retinoic acid, which is an isomer of vitamin A, has specific action on these APL cells, promyelocytes, which causes it to differentiate. And then there was the introduction of the arsenic trioxide. All these drugs have ability to cure the patient completely. I'm not telling it has the ability to reduce the symptoms of AML. It has the ability to cure the patient if the patient is able to take the treatment for a period of 2 years. Here I want to highlight that what is important in the treatment of APL is we have to suspect that it could be APL in the very beginning. When the patient presents with abnormal WBCs and low platelet count. Here it is mentioned abnormal WBC count, but I want to highlight that even with a normal WBC count and a low platelet, patients could have, some APL patients could have a WBC count between 4,000 to 11,000, which is a normal WBC count. Hemoglobin may be normal, at which point of time the chances of it being treated as a viral fever is very high. So every case of thrombocytopenia, ask for a peripheral smear, and every case of thrombocytopenia, don't push it off, calling it as a viral infection. Don't push it off, calling it as an ITP. So there are specific treatment ATRA and ATO. The patient should also be able to take the treatment for an extended period of time. The patient should be free from the disease cells, the MRD negative, for at the end of a certain amount of time. And by the end of 2 years, if he is still MRD negative, the patient is likely to be fully cured. What are the challenges for me treating APL in a peripheral place like this, we need the support of blood bank. We need to keep the platelet count steady. We need to keep a good amount of fibrinogen, and this has to come from good blood products which have been checked well, which have been stored properly in proper temperature, and it has to be issued in the proper time. We have to keep giving this every day. When I say I have to maintain a platelet count of 30,000 for a patient who's daily getting chemotherapy, I will probably have to transfuse him with platelets every day, which means that the donors have to be there. And it's very difficult. Suppose it is a 32-year-old patient who is walking, talking well, working, self-reliant. Suddenly he has a headache. Suddenly he comes with an APL diagnosis. He is working in a remote place. He is probably staying in as a PG in some city. His parents are in a remote village. To get the donors for every unit of blood product that he requires is very difficult. It is important that we sit together and have policies that some of these patients will get blood products even without donors, because there is some value that we can actually save this patient's life. These are some of the studies that have been done with ATRA, with chemotherapy, ATRA versus chemotherapy, etc. So what I said here was the highlighted in this article, which says that the outcomes, APL remains extremely deadly upfront, with such outstanding outcome restricted largely to those in whom the diagnosis is actually suspected. This is exactly what I said in the previous slide. Treatment with ATRA is started immediately, and suspicion of APL, that is, as soon as you suspect APL, we'll start with the treatment with ATRA. We don't even wait for the peripheral smear report. We don't even wait for the CBC. And then we have to maintain the coagulation parameters. We have to prevent coagulation abnormalities. And then referral to the hematologist early is very important. So there are several causes of early death. Early death is increased with delay in APL diagnosis. If you don't look at the slide, you will miss it. Delay in ATRA initiation. If you do not have ATRA in my bag, if it is not there in my drawer, it is not there in the pharmacy, we have to ask for it, we have to courier it, we have to get it from the, it will take a lot of time. Delay in hospital admission, old age of patient, admission to non-teaching hospitals, because certainly the non-teaching hospital is not likely to get blood products, and donors are more likely to come forward in a teaching hospital probably. So these are some of the regimen that are used in in APL treatment. So these are some cases which I wanted to highlight. Thank you. If people are willing to listen, I will go back to the classification of hematologic malignancies and highlight where we are likely to miss the diagnosis of each of them. From a clinician point of view, from if people from other specialties are listening, if the general physicians and rheumatologists and pulmonologists, if you are all listening, if it is very common to use steroids in a rheumatology practice, pulmonology practice, general physicians are likely to use steroids very often, but many of the lymphomas could be masked. This is what I wanted to highlight. Should I continue explaining each of the hematologic malignancy? Are people still listening to me? Okay, I will take the silence as a yes. So I'll just go on highlighting where we can miss the diagnosis of some of these conditions. This is the WHO classification which we saw earlier. From a clinician and lab perspective, monoclonal B-cell lymphocytosis is likely to be asymptomatic, so also CLL. Hairy cell leukemia may have a presentation of splenomegaly. Unless the splenomegaly is very huge, and unless you do a hematologic examination for the splenomegaly, only if you ask for a CBC, you will know that it is hairy cell leukemia. The CBC could be normal in hairy cell leukemia. The WBC count could be normal. The neutrophil count could be normal. Lymphocyte count could be normal. The only thing is monocytes could be less in number. Unless you look at the morphology, you are likely to miss all the splenic B-cell lymphomas and leukemias. We can go on and elaborate these things in a separate session. But in this talk, I just want to highlight where each of these conditions are likely to be missed. Extranodal marginal zone lymphoma of the GI tract could be mistaken as a epigastric discomfort, peptic ulcer, etc. Certainly, it is a peptic ulcer and all are known to predispose to these conditions. Cutaneous malignancies and follicular lymphoma, from a laboratory point of view, it can look very similar to a reactive lymph node. Then there are the various transformations of indolent lymphoma to the large B cell lymphomas. Even a large B cell lymphoma, diffuse large B cell lymphoma, may not be symptomatic. The patient may have just tiredness and weight loss, and the patient may attribute this to a good dietary modification which he did for his diabetic primary diabetes, or he may have been obese in the past. He may be having diabetes. He may just say, You asked me to do a good walk. I've started walking and now I've lost weight. There's nothing to worry. So these are certain places where we could miss the diagnosis. Then there are plasma cell neoplasms like plasmablastic lymphoma and multiple myeloma. Then there is the Burkitt lymphoma. Burkitt lymphoma is likely to be diagnosed. It is not likely to be missed because it is so dramatic in its presentation. So here, what I wanted to highlight in this classification is that lymphoproliferative neoplasms can be associated with certain immunodeficiencies. Whether the immunodeficiency could be congenital immunodeficiency syndrome, or it could be some infection like HIV, or it could be iatrogenic in a diabetic patient, in a patient who is on long-term steroid, whether the patient is on steroid because of some prescription or the patient is taking over-the-counter steroid. So Hodgkin's lymphoma is known to have a younger age at presentation, and therefore a Hodgkin's lymphoma patient could be passed off as an ITP or some other simple anemias unless he actually has a peripheral lymphadenopathy. Cold agglutinin disease was earlier thought to be only a hemolytic anemia, but there is a high prevalence of various lymphomas and monoclonal gammopathies in cold agglutinin disease, and hence it requires extensive workup. In the last week, I had a cold agglutinin disease patient. I told them, you may recover, but I would suggest you go for a bone marrow. The patient thought I was just looking for cases and I'm a crazy lady looking for people to marrow and just fill my pockets, probably. That's what she thought, probably. And but there is some value in early diagnosis because some of the lymphomas which are associated with cold agglutinin disease have oral medication. You need not go for a chemotherapy. Full fledged IV chemotherapy may not be required. You may just be cured by a oral targeted agent. And then there are T cell lymphomas. The problem with T cell lymphoma, whether it is cutaneous T cell lymphoma or the other anaplastic large cell lymphomas, is that there are a lot of reactive cells in the background and there are a lot of benign B cells in the background. Therefore, they could be missed unless you are getting the slides seen by someone who wrote the WHO classification. So coming to the lymphomas of the GI tract, these also have very vague symptoms unless you have done a biopsy, and unless the biopsy has actually picked up the malignancy, you may miss it. I think I have highlighted about the myelodysplastic syndrome previously. And then we often, after the bone marrow aspiration biopsy, hematologist, we often ask for a sample to be kept for cytogenetic examination and also molecular evaluation, and that test is ordered after the diagnosis is made. So there is a very difficult situation for us because when even to convince the patient that you have been diagnosed with malignancy is one thing, and then to tell him that you have to pay money for the additional sample which I had taken, and you have to get this done to know whether what is the prognosis. I have had a few patients who have told me, I really don't want to know. This was shocking enough. I do not want to know whether I will live for 3 months or whether I'll live for 3 years. That is quite understandable given their situation, that people expect each of them individuals to survive for a long duration based on the various practices they have, health practices they have adopted for themselves. So, lot of molecular investigations are done for hematologic malignancies, and each of them has prognostic significance. If the patient wants to know, we can do it. But what I have seen in the peripheries here is that they really don't want to know. Thank you.
Thank you, ma'am.
Thank you. Thank you so much. I would like to thank Hetero Oncology, Mr. Jagdish and Mr. Sampath Kumar. Thank you.
Thank you, ma'am.